The information in this podcast is provided for education and research information only. It is not a substitute for professional health advice.
Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And today on the podcast we have a maternal fetal medicine specialist.
This is exciting.
Yeah, very exciting. We have Professor Joanne Said, and she's the head of maternal fetal medicine at Joan Kerner Women's and Children's at Sunshine Hospital. Now, she is very much into research, isn't she? And we talked to Jo about her 2 trials that she's doing.
Yep.
The C-steroid and the pre-seed trial.
Yeah, and also the life of a maternal fetal medicine specialist in general.
Yeah.
What they do, who they see.
Yeah, I think it'll be really useful for anybody that is going along in their pregnancy, maybe have gone through their 20-week scan and all of a sudden they've been referred to a MFM.
Yeah, for some, perhaps an abnormality found on a scan or because a disease they already had before they were pregnant is starting to act up during pregnancy, typically things that are rare-ish. We refer to maternal fetal medicine specialists for their expertise in managing these unusual and rare things. Welcome, Jo. Welcome to the podcast.
Thank you. Thanks very much for having me.
Thanks for coming on. We're really excited to speak to an MFM specialist. We want to do a bit of a deep dive into the subspecialties, particularly the obstetric ones, and get some more leading light experts on our podcast to help everyone know more about their care.
Yeah, and about who they potentially might see in their care. So, Pat, you've started with MFM, so fabulous. Joanne, what is an MFM?
MFM is a maternal fetal medicine subspecialist. So typically we are RANSCOG practitioners, so obstetrician gynecologists. We complete the 6 years of ONG training through the Royal Australian New Zealand College of ONG. And then we go on and do an additional 3 years of subspecialty training, specifically in high-risk obstetrics. So we focus on ultrasound, we focus on diagnosis of fetal abnormalities, we focus on maternal medical disorders, so really complex maternal medical disorders. So they're the sorts of things that we do. A big component of MFM is understanding the research environment and trying to develop the specialty as well, and really just making sure that we're providing the best possible care to patients with the most complex pregnancies.
I want to labour that point that you just made. So you said 6 years of ONG training, but before that you've already done an undergraduate of, 6 years? Is that about right?
Yeah. Are you nuts?
Are you nuts? That's my thing.
We are professional student trainees. I guess it does take many, many years to complete the subspecialty. And for many of us, it's not a linear path. I also did a PhD during that time as well. So a PhD is 3 years. So I did my 3 years of PhD, my 3 years of MFM training concurrently. So that turned into 6 years. So it's been quite a while before you are actually fully qualified. Now, that's not to say, of course, you're working during the time and you're contributing to the craft and to the specialty and doing a lot of on-the-job training. So our fellows are highly experienced, usually fully qualified obstetricians by the time they become fellows to work with us. And so then they're learning that additional craft of high-risk obstetrics. Many of our MFM subspecialists also do a DDU, so a Diploma of Diagnostic Ultrasound, which is 2 years, usually, again, done concurrently just to really get that expertise in ultrasound and ultrasound diagnosis. So highly qualified people.
Yeah,
absolutely. We're going to get onto that a little bit later, but that's because you guys do a lot of the ultrasounds yourselves, don't you? That's part of your job is re-ultrasounding people where an abnormality has been found elsewhere, right?
That's correct, yeah. So we do a lot of the hands-on ultrasound ourselves. And we do ultrasound procedures, amniocentesis, CBS, those sorts of procedures as well.
All right. So, Pat, as a general obstetrician, when would you use an MFM?
Well, in preparation for this question, I looked back over perhaps the last half dozen MFM referrals I've made in my general specialist obstetric practice, and it's almost all twins, Jo.
Well, certainly in my practice, I work in a public hospital. We don't have the capacity to see all twins, but we see all the monochorionic twins.
Yeah.
So the twins that share one placenta, they're the most complex and they're the tricky ones that give us a hard time. So we see all the complex twins, but I'll also see the twins that have separate placentas if they've got additional complexities. So there might be one baby's not growing so well, or there might be an abnormality in one baby, things like that. But we see a lot of twins, yes.
Yeah. And the other things that I've reached out for help for have been infections. Is that a common part of your work?
Yeah, that's right. So CMV is probably one of our, a reasonably common referral. So cytomegalovirus, suspected infection in pregnancy, but we also see things like parvovirus in pregnancy. Yeah, we see a lot of, infections in pregnancy. Obviously, during the COVID pandemic, it was the MFMs who were kind of initially leading that kind of the charge of managing the complex COVID patients when it became, a much milder illness, particularly after everyone was vaccinated. We sort of handed it all back to the general teams. But in those early days of COVID, it was the MFMs at the various tertiary hospitals who were really leading that pregnancy care for COVID in pregnancy.
Yeah.
Can I ask, with somebody, say, Pat, you've suspected CMV or have and for anyone listening, we've done an episode on CMV.
We have a well-received episode.
Not that long ago, actually. So just go back into our back catalogue and have a refresh on what that all is. But say someone's had CMV, what is their pathway to get to an MFM?
Well, I think typically they would be under the primary care of a public obstetric unit, general unit most of the time, or perhaps a private obstetrician. And in the setting of something like CMV, unless that person was particularly well versed in that and considered themselves on top of all aspects of it and so forth, then we would put in a phone call to someone like Joanne and say, look, here's what we know so far. Here's our blood results. Could you see this patient? And there's kind of two possibilities. One is that the patient might be essentially taken over in a subspecialist unit like Joanne's, where they would manage the very pointy end. For example, someone who had not only been exposed to CMV, but there was a proven fetal infection. On other occasions, and the patient goes down to see someone like Joanne in their unit, gets an opinion and a clear plan, but remains part of the unit that referred them in the first place.
How often, Joanne, are you present at a birth, or is it by then that you've handed that patient back to their obstetrician?
So that's exactly right. We do a lot of kind of secondary consulting and handing back to obstetricians. However, I don't do a lot of births these days. I'm busy with the research and the ultrasound and things like that. And so usually we spend a lot of time making the plans and then liaising with the local team to organise the birth, whether it's an induction or a caesarean section or waiting for spontaneous birth. But we might make those plans. And sometimes we'll need to liaise with the local neonatologists as well if there's special treatments that the baby might need afterwards. But all the time we make the plans. Now, there's certainly some MFM obstetricians who will also still do their own births and things like that. And so generally, MFMs will often get involved in some of the really complex births. But equally, a lot of them will hand them back to the general obstetricians to manage the births.
And are most MFMs a public practitioner or a mix of public-private? Do people see private MFMs? How does somebody see an MFM?
There are definitely some private MFMs. Most MFMs around Australia are generally working in public tertiary centres. There are a few MFMs working in the non-tertiary centres as well, and there are a few private MFMs. There are certainly quite a few private MFMs who do just the ultrasound component of their MFM work in private, but most MFMs are in the public tertiary centres. That's where the big MFM units usually work.
Because I could imagine if you're seeing an MFM by that stage, if you were seeing that person privately, it would be starting to add up.
In the private sector?
In the private sector.
Yeah. I've had one private patient who went to a private MFM service in capital city, and it was getting more expensive, and they wound up in the getting expert care in the public unit down the road, and that went beautifully well for them.
Yeah.
Mm.
I think one of the advantages of MFM in the public units is MFM is often a very multidisciplinary kind of specialty. So we often need the input of our neonatology colleagues. I work very closely with fetal cardiologists. I work with genetics, geneticists, genetic counsellors, midwives, obstetric medicine physicians. And on a day-to-day basis, I've got all of these people that I can be talking to best manage patient care. And so that's one of the benefits of working in a public hospital, that multidisciplinary team. It's a little bit more challenging sometimes in the private sector because you've got to kind of pick and choose all those individual specialties. And you've often got a lot of people working behind every single pregnancy.
We've talked when Pat might send someone to an MFM during pregnancy, but do you work with people that are trying to get pregnant that have got a known genetic issue?
Yeah, so we do a little bit. We have a small pre-pregnancy counselling clinic. It's been really challenging having that sort of a clinic just because the demand for the pregnancy-related work means that we don't have as much capacity to see people planning pregnancy, and we'd like to be able to do that more. But yes, it's really important. Certainly people with chronic medical disorders, it's really important that they have their care optimised prior to pregnancy, and that's where an MFM can help with that. But also with underlying genetic disorders, yeah. Yeah,
sorry, Jo. What medical disorders are you referring to there? Because this is a bit of an interest of ours, is getting people with pre-existing medical conditions as good as possible before they get pregnant.
Yeah, so some classic examples. Type 1 diabetes is a really classic example. We know that getting the control as good as possible prior to conception really helps to reduce the risk of miscarriages, stillbirth, but also fetal abnormalities. So that's a really good example. There's diseases like lupus, SLE, or inflammatory bowel disease, where we know that if the disease is as quiet as possible, so if you've got it under really good control prior to conception, that actually helps to improve the pregnancy outcomes. And for a lot of those conditions, sometimes the treatments that you would give to get the disease under control aren't necessarily as compatible with pregnancy. So it's about making sure that we time, get the disease under control and then time the conception as much as possible when the disease is under control, but where people are off medications that could be more harmful during pregnancy. And then I guess the other area that we work in is people who've had organ transplants, so kidney or liver transplants prior to pregnancy. They become really complex pregnancies because, again, you don't want to put the transplanted organ at any risk. So you're managing mum, but you want to make sure that you're optimising their condition as much as possible before and during the pregnancy. So we do a lot of that sort of care for the really complex patients prior to pregnancy.
So, Jo, I don't want to worry all our listeners. What sort of percentage of the population would see you as an MFM, do you think, in a high-risk pregnancy?
A statistic? I don't have one off the top of my head, to be honest. The types of conditions that we see in MFM, it's the conditions that have a prevalence of less than 1%. So if it's that common, less than 1% of the population, of the pregnant population have got it, then it's probably something that probably needs to come and see an MFM. So that's a good rule of thumb for particularly maternal medical disorders, but also the fetal abnormalities and things too.
Jo, I'm interested, in the real pointy end of the referrals that you get. How much of that is really bad news for people? I've always thought your job involved a fair bit of saying to people, look, you've been referred with a highly abnormal 20-week ultrasound and it's something we can't fix. Is that a daily or a weekly challenge for you?
That's not an uncommon challenge for us. And our job is really about making sure that we get the diagnosis correct for people, and make sure that we're giving people the best possible information about the diagnosis, the prognosis, the outcomes, and what can and can't be done. And that's a really important part of our work. It's also important that people have choices over what happens with their pregnancy. But of course, you can only make a choice and a difficult decision sometimes when you've got all the information that you need. And our job is to walk with families through that pathway, getting all the information that they need from the various different subspecialists that we work with, the genetic counsellors, the geneticists, our cardiologists if it's a heart problem, getting all of that information so that we can counsel families properly and give them as much time as they need to help make that decision. So it's a big part of our work. At the same time, there is also some wonderful parts of our work, and a beautiful example is sometimes when you've cared for a family who've had that very difficult pregnancy and sometimes had to, had a baby diagnosed with major abnormalities. They'd made a difficult decision to possibly end the pregnancy. And then we're seeing them again in the next pregnancy.
Yeah.
We know that they're going to be very anxious and concerned. So we'll do those extra scans. We'll check from an early gestation just to make sure that, the same condition hasn't recurred. Look for any other abnormalities. And that's one of the real joys for me, is then being able to support people in their pregnancy journey during the next pregnancy. And that's another really good example of that is people who've experienced, for example, recurrent miscarriages or a very early extreme preterm birth and potentially lost the baby. We then put interventions in place in the next pregnancy to help get them through the next pregnancy. And that's a real joy and a really, really good part of our work.
Fantastic.
When it comes to things like a preterm labour, do you see all preterm labour issues or, whether they've ended up losing that baby? Say, for example, having insufficient cervix. Is that something that you do as well? Or, it's just I'm trying to get a handle on when people would see an MFM and when they would still go back to their general obstetrician.
Yeah, so that's a really good example, the preterm birth clinic that we run here. So we will see patients. So I couldn't possibly see every patient who's in preterm labour. We will often counsel people who might have ruptured their membranes at 20 to 22, 23 weeks at that kind of borderline viability. We might kind of counsel them about what they're going to do in that current pregnancy. But a really big part of our work is people who've had a preterm birth will come to our cervical surveillance clinic, and we will see them usually from about 14 or 16 weeks. We will offer them cervical surveillance, which is where we scan their cervix every 2 weeks looking for cervical shortening. And then we offer them a range of treatments according to kind of their personal situation. So we might offer progesterone, we might offer a stitch, a cerclage. So they're the sort of patients that we see, and then we care for them through our cervical surveillance and preterm birth clinic. And we have a dedicated preterm birth clinic staffed by midwives as well, who also then provide some of that ongoing care when we talk about patients graduating from our cervical surveillance clinic. So if they get to 26 weeks, things are going well, we usually then let them continue their care with our preterm birth midwife just to provide that additional support for their pregnancy.
You mentioned that if someone was to come and see you, you do some tests. So you mentioned amniocentesis and the CVS. Can you just describe what somebody would expect when they come to see you? What do they have to prepare for?
Yeah, so if patients are referred for invasive testing, so often these are patients might have had an increased risk result on their NIPT, for example. It shows a high risk of Down syndrome. They would be referred to us for invasive testing. And typically in our unit, we ask them to see our genetic counsellor first, who will talk about the different options available. CVS testing can only be done at a certain gestation. So typically we do it somewhere between 11 to 14 weeks gestation. And CVS testing is a good test in certain circumstances, but it's not always the best test. Amniocentesis we typically do after 15 weeks gestation. And both of those tests, we are very good at testing for the chromosomes. So we generally do a chromosomal microarray, which is a very detailed genetic test, which is basically close to 100% accurate. And so there's a really important aspect in that pre-test counselling, so preparing people for the test, making sure they understand the process of the test and what to expect during the test, when to expect the results, and also just thinking about, what are they going to do with that information? Now, people haven't always necessarily made a decision about what they want to do with that information. They want to wait for the test result, but it's important that to start thinking about how we're going to manage that discussion once we've got the results and what the next steps might look like. So we use our genetic counsellors and spend a bit of time talking to patients themselves. The procedure itself is fairly straightforward. It's done under ultrasound guidance. Takes just a few minutes usually to get the sample, and people might expect to get a little bit of crampy pain afterwards. Usually only for an hour or two, and usually by 24 hours or so, everything's they're feeling pretty good. But the procedure itself is fairly straightforward. But it's all that counselling around everything else.
The decision making's the tricky bit, right?
Yeah.
That's right. Yeah.
Jo, we're really interested in the research that you're doing at the moment. Can you tell us about some of the things you're involved with right now?
Absolutely. So I currently lead the PROCEED trial, and I'm also the Australian lead for the C-steroid trial. So both of those trials are exploring antenatal corticosteroids when given to mums prior to caesarean section at term. So antenatal corticosteroids have been around for over 50 years. We use them when women are going into preterm labour. We know that corticosteroids help to improve the breathing problems in babies, so it helps to reduce the risk of breathing problems in babies born preterm. Unfortunately, we know that with caesarean section, babies that are born by caesarean section are a little bit more likely to have breathing problems compared to babies that are born vaginally. And those breathing problems are usually fairly short term. They might last a day or two. But it does mean that sometimes those babies do need to be admitted to the nursery, have a little bit of support for breathing. And so what we're wondering is whether giving corticosteroids to women before caesarean section, whether that helps to reduce those breathing problems. And so what we're trying to do is do a randomised trial to explore that question. And so the C-steroid trial is for women without diabetes. So we recruit them to 7 days prior to their caesarean section, and we give them 2 doses of corticosteroids. So one dose and then a second dose 24 hours later.
Can I just ask for a moment? These are people at term, are they?
These are people at term. That's
right. Okay.
So between 35 weeks and 39 weeks and 6 days.
Yeah, okay. So this, just for the benefit of people listening, this is much later than we would normally be giving corticosteroids. We think of those as a bit of an insurance policy for a baby that we're going to deliver in the sort of late prematurity phase where there's a known benefit, but we tend not to do it on current evidence for babies that are close to term.
That's exactly right. And we don't have good quality evidence to say whether it is beneficial or not. There have been some studies that suggest that it's beneficial, but we just don't know whether it is beneficial or not. So that's whenever we don't know whether a treatment's beneficial or not, we would do a randomised trial. And a randomised trial is where we randomly allocate people to receive the corticosteroid injections or the placebo injections. And so we don't know what they're getting. So they get 2 injections, and then we will look at the results. We'll look to see whether their baby did get breathing problems or not. We're also testing the babies to see whether corticosteroids affect their blood sugar or not as well. We think that corticosteroids might be associated with a low blood sugar, but we're not sure. So by testing for that, we can check. When it comes to the PROCEED trial is for women specifically with diabetes.
Okay.
And this is a really important trial because women with diabetes are normally excluded from randomized trials of corticosteroids. And so we don't know whether corticosteroids are effective in women with diabetes. But we also know that women with diabetes are more likely to give birth by cesarean section. They're more likely to give birth a little bit earlier than women without diabetes. And just by having diabetes, we know that the babies born to women with diabetes, they're a bit more likely to have breathing problems. So theoretically, at least, women with diabetes, their babies have the most to benefit from an intervention of corticosteroids if it's effective. But because we don't know whether it's effective or not, we shouldn't just be giving corticosteroids at this term gestation. Very different for the very preterm gestations. But at the term gestation, we shouldn't just be giving corticosteroids unless we know that it is effective. And so that's why we're doing, again, another large randomized trial where we randomly allocate people to either receive the corticosteroid injections or the placebo injections. And then we'll look at the results and see whether the corticosteroids are effective at preventing breathing problems. Because there's no point giving people corticosteroid injections at that late term gestation if it's not causing any benefits. But likewise, we don't want to not give people a treatment that we know to be fairly safe if it is going to give good benefits. So we just really need to make sure that it is beneficial or not before we start recommending this as routine practice.
Yeah, okay. And if you can demonstrate a clear benefit in the diabetic women in particular, then the benefit for the baby would ultimately outweigh the disturbance to the mother's diabetes control by giving the steroids.
You're absolutely right. And, we know that if we can prevent the babies from having to go to the nursery, that might improve things like breastfeeding, establishing breastfeeding and things like that. So that might be a really good thing. We do know that corticosteroids do cause mum's blood sugar to go a little bit high. But we also know that can actually be fairly easily controlled by just adjusting the insulin doses. So we can manage that if it's going to be beneficial. But of course, there's no point giving these injections if it's not going to be of any benefit to the baby.
Excellent.
And where are you in terms of the process? What sort of year are you in for both of those studies?
So these are really big trials. Funded through the Medical Research Future Fund and National Health and Medical Research Council. So really big trials that are running all over Australia and New Zealand. So C-steroid started first. So that started in New Zealand back in just before COVID times, in fact. And they've been going for a while, and Australia joined in 2023. And so we've nearly recruited 50% of the total sample size for C-steroid. So we've got another 2 to 3 years to go in recruiting for C-steroid before we'll be able to analyse those results and get the results. The PROCEED trial has only just started, so we've just started recruiting in Australia, and New Zealand came on board about 2 or 3 weeks ago. So we've still got another 4 or 5 years of recruiting before we're going to get those results. These are really big trials, and of course, to be absolutely certain that we've got a correct result, we need to recruit a fairly large number of women. So, we've got to recruit over 2,000 women to these trials to really demonstrate that it is effective. We only get one shot at doing these trials, so that's why we've got to make sure we've got the right number of people in the trial to make sure that we do it properly and get the results that we need.
And
Brilliant.
would it be that some of our listeners might come across this in their hospital information, that the hospital's part of a pre-seed or a C-steroid study?
So that's correct. We're recruiting for C-steroid and pre-seed all around Australia and New Zealand. So if people see the banners or the flyers in their hospitals, there'll be staff that they'll be able to talk to about these trials. There are midwives who support recruitment for these trials. And we've also got websites for C-steroid and pre-seed. Unfortunately, women are only able to participate if their hospital is recruiting for C-steroid or pre-seed. But if you're at a site that's not recruiting for C-steroid or pre-seed, perhaps you can ask them and see whether we can get their hospital involved in recruiting for these trials. We feel that it's really important that women have the opportunity to participate in trials that may provide benefit and give us the answers that we need that will improve the health of mothers and babies in the future. So that's why we think participating in trials is a really good thing to do.
There we go, listeners. You've heard it here.
There you go.
If you come across that, say yes.
Yeah, look, the times in my career when I've been involved in recruitment, which to be honest was mostly when I was a registrar at the Women's, which is where I first met Jo, it always surprised me how keen and happy to be involved people were once the dilemma was explained to them. We're going to give you this drug or not give you this drug, and you won't know and we won't know whether you've been given it or not. People are confused and you say, because we honestly don't know. And then occasionally people would say, just give me the one that works. and you'd say, yes, well, we don't know. That's the whole point. I'm still impressed by people's willingness to be involved in clinical trials and their sense that they're doing something for the future women.
Yeah.
I think that's exactly right. And that's what we're seeing in these trials is that women are willing to be randomised. When giving a treatment that is unsafe or anything like that, we wouldn't do that. We're giving a treatment because we don't know whether it's effective. And before we started these trials, a lot of obstetricians were routinely giving corticosteroids. So you'd go to one hospital where women were routinely receiving these steroids before caesarean section, and you go to another hospital where they weren't receiving them. So that doesn't seem fair. So we thought it's better to figure out whether it's effective once and for all so that then women can actually, participate and contribute to that knowledge, and then we can tell them in the future whether it's good to give it or not.
I want to go back to about placental abnormalities because we get so many questions about people with placentas not attaching properly or the placenta artery, single vessel cord and marginal cord insertions and suction turret lobes and so forth. Yeah. Because there's not much information out there on that. So how often do you have a referral for a placental abnormality?
We receive lots of referrals for placental abnormalities. So in general, more routine things, placenta previa, we let our general teams deal with even single umbilical artery. It's so common. And as long as we've had a really good look at the baby and there's no other, problems, a single umbilical artery is just, an incidental finding. It's not going to cause any problems. We recommend usually some growth scans. It's a very small increased risk of having a small baby, but it's only a very small increased risk. So by just checking the growth, that's a reasonable thing to do. There are so many other cord abnormalities and things like that, and most of them are fairly just incidental findings, and provided they've had a good quality morphology scan, making sure that there's no additional abnormalities. They're not things that we particularly worry about. Vasa previa is something that we do worry more about, and that can be associated either with a previous placenta, a low-lying placenta that's now moved out of the way but can leave a little vessel behind that can cross the cervix, and that can be a risk because it could rupture during the labour. So it's important that we detect it, monitor it, and usually we would deliver those patients by caesarean section. So often we do get quite a few referrals for suspected vasa previa, and that requires a very careful scan to look and exclude it or diagnose it if it's there. So we usually do see those ones, but a lot of the other things don't necessarily need to come to an MFM, provided they've had a reasonably good quality ultrasound scan, and most of those other things have been excluded.
I know that Pat talks a little bit about COGUS. What's the difference between an MFM and a COGUS? I know they're two abbreviations and our listeners need to know them.
MFM or CMFM is our qualification, Certificate of Maternal Fetal Medicine. COGUS is another certificate, advanced subspecialty training. So COGU or COGUS, Certificate of Obstetric and Gynecological Ultrasound. And they're basically similar in that MFMs and COGUs have both done an additional 3 years of subspecialty training. Whereas the MFMs focus on the high-risk pregnancy, we don't usually do any gynecology, although there's a few people who still do gynecology if they're MFM. And we focus a lot on also the counselling and the pregnancy management and the obstetric medicine kind of aspects as well. Whereas the COGUs focus mostly on the ultrasound. So they will do, like MFMs, they'll do diagnostic procedures, but they'll also then do the gynecological procedures that we don't do. So they'll do the tubal diagnosis of tubal patency and things like that. They'll do saline hysteroscopy. They might do ovarian cyst aspirations. So most MFMs won't look at gynecological things. And the COGUs generally don't get quite so involved in the obstetric management, so the pregnancy care, whereas an MFM person will generally get involved in the pregnancy care. But then, like I said, we'll still often hand the patient back to their general O&G for further management and delivery. So that's probably the broad difference.
Right.
Similar, and in terms of the obstetric ultrasound components, there's a lot of overlaps between the COGUs and the MFMs.
Yeah, right.
Good.
Okay, people, you'll probably hear those terms if you need either one of those specialists. In the last, 5 years or whatever, what's some research that's come out that you've gone, wow, this is really fabulous, earth-shattering, life-changing research for the O&G world?
Oh, goodness, you put me on the spot. There are so many things.
You can have thinking music.
There are so many things. I think, and I love going to conferences and hearing new things. Obviously I've spent a lot of time focusing on the steroid work and, there's some really big trials looking at steroids in late preterm birth, for example. But also we talked earlier about CMV, and some of the treatments for CMV have been really, really impressive. But also the way we manage patients with transplants has really kind of changed a lot these days. And there's some really big studies looking at that. And then, of course, in the preeclampsia domain, the issues around screening. So, the approach to improving our detection of patients at risk of preeclampsia. The ASPRI trial was a really important trial that showed that when we, screen and detect people at increased risk of preeclampsia, then giving them some aspirin really significantly reduces their risk of preeclampsia. So another really big research field is, of course, all the work that's being done with NIPT and genetic testing in pregnancy, and of course the genetic carrier screening, the Mackenzie's mission to diagnose carriers of genetic conditions. All of those really big research trials, and they do require our patients to participate in those trials, and it's only through that sort of participation that we do get the answers that we need to really help to improve the care that we provide for pregnant women. When I look back and think when I first started training many years ago, and I remember Pat obviously working at the Women's, and it was great, but the things that we were doing back then are actually very different to many of the things that we do these days because of research. And we've got so many different interventions for, preterm birth is a classic example, not just steroids, things like progesterone to prevent preterm birth. That wasn't around when I was training. Magnesium sulfate to prevent for fetal neuroprotection, the care that we provide for babies in the NICU, all of those things only happen through good quality research, and it really needs people to contribute to that research.
Jo, in your experience, when a research paper is released and it's been accepted as a good paper with lots of learnings, how long do you see that coming into common practice?
It's a really good question because it can be quite variable. So sometimes with treatments or interventions that are off the shelf, it doesn't take much and people will take them up and start giving them automatically. And a classic example of that, when I was involved, I did a lot of research on thrombophilia and giving heparins to patients. So there was a single small study that suggested that giving heparins to people with thrombophilia improved their pregnancy outcome. So everybody rushed to give heparins, and heparin was thrown around. People getting Clexane or Fragmin, and lots of people were getting these injections until we did the big definitive studies that showed that those interventions weren't appropriate. And it took many years to get those big studies. But then sometimes it's harder to wind back the clock, and people were already doing it and saying, well, I think it works, even though there was no evidence to say that it works. So when you ask how long it takes, it really depends on the enthusiasm and whether the treatment's already available. Because likewise, if the treatment's not readily available, sometimes it can take 15, 20 years. And that was a classic example of antenatal corticosteroids. The first trial was published in 1972, but it took more than 20 years for steroids to be given routinely to babies at risk of preterm birth. And that meant for 20 years, those babies were missing out on that intervention. So it's one of the challenges.
What are your thoughts, Jo, on the carrier screening? So the one that the Medicare funds is only really for 3. Pat can help me out here. So Fragile X.
They can do Fragile X, cystic fibrosis and spinal muscular atrophy. And I guess there's technology to do more.
What do you think? Is that something that, it would be good for Medicare to fund, or does that raise more problems than it answers?
Yeah, look, that's right. So there's lots of different carrier screening options. And a lot of those carrier screening options patients can choose to pay for. Obviously, the more tests that you test for, we all carry kind of all sorts of things. So the more things that you're going to find. So the good thing about some of those much bigger expanded carrier screenings is that they provide a result for the couple. And so only if you're both carriers and there's a risk to the baby, because otherwise you get worried about all sorts of things that you could be carrying that are never going to cause a problem. So I think the way the counselling around that sort of carrier screening is really important, and that's where, the input of our genetic counsellors is just amazing. The challenge with then rolling that out into the public and making sure that Medicare could fund it, well, unfortunately, Medicare still don't fund NIPT. And yes, we know that Medicare is a limited pool and doesn't cover anywhere near all the things that we would recommend or need during pregnancy care. So if there was an unlimited bucket, you would absolutely offer everything to everybody. But unfortunately, the harsh reality is that there's a limit to the funding, and so they have to figure out how to best kind of spread it around. So they're focused on the more common conditions for now, and the ones that are much more, we've definitely got diagnostic testing for and an ability to influence the outcome.
Joanne, thank you so much for your time and also for your service to women who are having babies. 15 years to become an MFM. That's an enormous amount of your time to then create all this information for people.
Yeah, and we much appreciate your expertise, not just coming on our podcast, but the work you're doing every day is fantastic.
Thanks so much for having me. It was a real privilege to be able to talk to you today. Obviously, I'm very passionate about the work I do. It's a real privilege to be able to care for mums at the pointy end of pregnancy. I really love the work that I do. So thanks for having me.
Thanks a lot.
Thank you, everyone, for listening to that podcast with Joanne. Fascinating, wasn't it, Pat?
Fascinating. It's good to know, isn't it, that very, very highly trained and clever people like that are on the job looking after those rare and unusual conditions in pregnancy, but also spearheading the research.
Well, we hope you enjoyed that episode. And as usual, if you love our podcast, can we please ask a big favour that you follow it on whatever app that you listen to, share it with your friends and leave us a review. That would be very great.
Thanks for listening, everybody.
Thanks for listening. Bye for now.